Welcome to the Retreat Radio, where we go beyond temporary fixes and surface-level symptom management. Here, we dig into the real root causes behind your symptoms so that you can understand your body, advocate for your health, and ask the right questions. I'm Heather Witt, physician assistant and owner of the Retreat Wellness and Aesthetics. This podcast sits at the intersection of aesthetics, longevity, and functional medicine, and you'll get information without the sugarcoating, the trends, or the nonsense fluff. Let's get into it. Hello, everybody, and welcome back to the Retreat Radio. My name is Heather Witt, and I'm a physician assistant here in Newport Beach, California. And today's podcast episode is a continuation of what we talked about last week with the different forms of testosterone therapy. And today we're going to continue on with progesterone and estrogen. So this is going to be geared more toward the ladies this week, but we have a lot to get into, so let's jump in right away. So the first thing that I want to go over is just a very simplified explanation of the menstrual cycle and how estrogen and progesterone levels change throughout that cycle. So in the show notes below, I have like a little picture of the graph that's going to be right here on the YouTube version of this that you guys can follow along if you would like to. So the first phase of the menstrual cycle is actually the menstrual phase. So this is usually about days 1 to 5 or 1 to 7, depending on your cycle. This is the period where you are actually bleeding. And so this is what we consider day 1. This is the day that you first bleed. So anytime that we tend to ask, like, what day was your last cycle? What day of your cycle you are on? We're using first day of bleed as day 1. And during this time, both your estrogen and your progesterone are at a pretty low level. The next phase is the follicular phase. So this is the phase that is getting you ready for ovulation. So during this phase, your estrogen starts to gradually rise, but your progesterone stays pretty low. So as that estrogen continues to increase, we then hit the ovulation stage. And this is where an actual egg is released. And we say that this is usually around about day 14, but it really is different for every woman. And so unless you're using like LH test strips or you're, measuring via your temperature, your ovulatory status, you're never going to know exactly when this happens, but we estimate it to be about day 14. And your estrogen kind of peaks at that point and your progesterone starts to rise. Then you move into what we call the luteal phase. And during the luteal phase, your estrogen kind of has one more little bump or peak, but you have this huge surge in progesterone. And this is generally what we are looking for when we measure your labs. So this is why when we do your first set of labs, we generally like you to come in on day 19 to 21 of your cycle. Because if you're ovulating around day 14, around day 19 to 21, that should be when we are seeing the biggest peak in your progesterone to see what your actual levels are. So we use that in combination with your symptom profile to determine if maybe we need a little bit of help with that progesterone therapy. And then after this, both your estrogen and your progesterone both decrease pretty much back down to 0 or baseline. And this is then when we start the whole process over again. And that reduction in both hormones is what causes you to then bleed and shed that lining of the uterus. So that was an extremely simplified version of the menstrual cycle. There are lots of resources online and on YouTube of different creators who have done videos outlining this whole process. They also talk about LH and FSH, what that's doing during that time, and then what's actually happening in the uterus and the ovaries during the time as well. So if you want more info on that, there's tons out there already. I'm not going to recreate it, and I want to get into really the meat and potatoes of this episode. So let's start with estrogen therapy. Estrogen therapy can be used in perimenopause as well as menopause. Traditionally, it is used once you're in the menopause years when your estrogen virtually depletes to 0. However, there have been a lot of recent studies that have been looking into the benefits of starting estrogen therapy a little bit earlier toward the end years of perimenopause. However, at our office, we're still not really supplementing during this time unless there's some type of anomaly going on or another reason for it. But once we get into those menopause years, estrogen plays a huge role in so many other things in our body besides just reproduction, which has obviously come to a halt at that point. It helps us with our brain, so cognition, mood. It helps with our skin, our bone health. It's a huge preventer of osteoporosis. It also helps us with temperature regulation, and it also is a big driver of our cardiometabolic health. So it's a very, very important hormone, not to mention that when we do supplement this, you feel 1,000 times better. So there are lots of different forms of estrogen therapy we can use. Let's move through each one, and I'm going to give you some pros and cons of each one and what we like to use here in our clinic. There are a couple different kinds of estrogen we use. So first, we use a systemic estrogen. So this is when we're actually trying to change your systemic levels of estrogen in the body. And then we also use vaginal estrogen, and this is going to be more of a local effect to work directly on the vaginal tissues. So this is going to be for symptoms like vaginal dryness. It helps with preventing UTIs. It helps keep everything lubricated. It helps bring back some kind of that suppleness and plumpness to the vaginal area when it starts to atrophy over time. And it really helps with a lot of that pain during sex that you can feel as you get into those menopausal years. And when you are using a vaginal estrogen, it's a much lower dose, and you're not really going to get much of a systemic effect from it. So you can still have depleted systemic levels of estrogen, even if you are using a vaginal cream. So the two cannot overlap. You often will need both of them. But we use a lot of vaginal estrogen in our perimenopausal patients as well, because even though they might not be in full-fledged menopause, they may still be having the start of some of those symptoms. We also use a lot of vaginal estrogen cream on the face, which is really amazing for an anti-aging effect. Mix that with a little bit of GH copper. I'm telling you, it's just fabulous. When we're talking about vaginal or facial estrogen, we are strictly using a cream, and there's lots of different formulations. You can do straight estrogen. You can combine all three forms of estrogen. You can add in DHEA. You can add in testosterone. You can add in GHK copper. So there's lots of different compounded forms that you can get. When we're talking about systemic estrogen, let's first talk about creams. Creams are likely usually covered by insurance. Most of the forms that we're going to talk about are going to be covered by your insurance. So this is something that I just call into your local CVS, and it's usually not a problem. But just as when we talked last week about testosterone creams, estrogen creams that we use for systemic effect can also have varying degrees of absorption. So again, at our office, we really don't find too successful of a time with this because one woman may react much differently to it than another woman. And certain days of the week or times of the month may also change depending on how well you're rubbing it in. And once again, we also have that transference issue where if you are around children or pets and you're not careful about where you are putting it, you can also transfer it to them as well. So this is not a therapy that we generally use at our office. We much prefer the estrogen patches, which are usually really, really small, little thin patches that you can put on your lower abdomen or your buttocks, and they stay on for an entire week. Or you can get the twice weekly ones. So you'll change them out twice during the week. And they deliver a certain percentage of estrogen that we want. We can choose the different strengths to your system throughout that week. And you want to continuously be on this. They work really, really well. And we have a lot of degree of variability in the dosing so that we can customize this to the exact amount that you may need. So some cons to the patches, because there are still cons with every form of therapy, are some people can have a little bit of an allergy or irritation to the adhesive on the patch. Sometimes just by switching out different brands or trying those twice weekly patches can fix the issue, but it still can be irritating for some. Another issue is that some people who do a lot of hot yoga or maybe go in the sauna a lot or like to soak in their hot tub can have a little bit of issue of, again, those patches sticking for the entire time that they need to be on. And again, usually for those type of patients, I recommend those twice weekly patches. Now, the biggest overall concern right now with patches is that I think we've made some really good headway in the bioidentical hormone space in getting all of that misinformation debunked. Re-looking at that WHI study, which if you guys have not listened to, I think it was our second podcast on me going through the WHI study and what it actually showed, I highly recommend you go back and listen to that. But I think that we have really gotten that awareness out there that estrogen is not bad. Estrogen is not going to cause you to have cancer. And so we've seen an explosion of providers being more open to prescribe these products and patients using them. And so the downfall of that is we are now seeing a shortage of patches in the market. So it has been a little bit of a journey for us with our patients on trying to find pharmacies that have any kind of patch at all, let alone the twice weekly patches. Or maybe they have a 0.5 milligram patch, but not a 0.0375. So we're not able to get the dosing that each patient may need. And so right now it's been a little bit difficult, but I would say the patches are one of my favorite forms. We still can have absorption issues, but it is very, very rare and far and few between. So it is one of my favorite forms. Another form that we have is oral estrogen. And this can either be in the form of birth control, but it also can just be in taking an oral estrogen. And I don't really agree with using this because when we use an oral estrogen, first of all, just like we discussed with the testosterone, is that it has to go through first pass, through the gut and through the liver. So again, we can lose some of the potency, but more importantly, estrogen specifically, when it goes through first pass in the liver, it does increase clotting factors and clotting risk. And so this can just be a little bit of a riskier form to be using in patients. And so it's something that myself and most providers have steered clear of. I do know a lot of colleagues in the industry who are using it more. I don't know if it's just because there's a reason why they like it or if it's strictly because of the patch shortage, but it is something that my research has not yielded enough safety data on. And so this is something that I kind of steer very clear of at this point in time, but hopefully there will be more research to come. So let's move into progesterone therapy. So progesterone therapy, I just love it. I changed so many women's lives with progesterone. So what progesterone does is it is a magical little pill that almost is like 10 pills in one. So the scenario that we hear all the time is middle-aged woman goes into her doctor and says, I'm tired. I have no motivation for anything. I'm not sleeping well, and I'm just pissed off at the world all the time, and I feel depressed. And they get prescribed a sleeping aid. They get prescribed an antidepressant. They are told, well, you are getting older, you have kids, you've got a lot on your plate, you're probably just stressed out. Do some meditation. This is like the traditional cliche of what happens to these women. If you just give most of these women a little bit of progesterone, you can almost fix every one of those things I just mentioned, because what physically is happening to them is their progesterone levels are plummeted and they're not getting that surge of progesterone that they need after ovulation, like we talked about in that luteal phase. And when they don't have that, they experience a lot of those symptoms that I just mentioned. So when we give them a little bit of progesterone, it helps calm them. It helps let them sleep better. It can help a little bit with those vasomotor symptoms. So when you start to have a little bit of those, you're not in full-blown menopause, but you're starting to have weird hot flashes. You're having those mood shifts and variabilities. Progesterone can help all of that. And it can also, it's not necessarily a treatment for depression, but it can almost act as an antidepressant instead of taking an antidepressant itself. So that's a little bit on what progesterone actually does. Another important note about progesterone is that if you are on an estrogen, you must be on progesterone to protect the uterus. Now, just because you're not on estrogen does not mean you still would not benefit from a progesterone, because you have progesterone receptors everywhere in the body, in the brain, in the kidneys, in the digestive tract, everywhere. And so taking progesterone can really help with all of those symptoms, as I already mentioned. So definitely it is required if you're on an estrogen, but even if you're not, it is a wonderful thing for most perimenopausal women. So before I jump into the different forms of progesterone therapy, I want to talk about one of the most common reasons that we use progesterone. Because I think a lot of people think that hormone therapy is only for menopause. And we are using a lot of progesterone in perimenopause. And why this is because we use it a lot to treat what appears to be an estrogen dominant situation. So sometimes on labs, we'll see that estrogen can be a little bit high, progesterone is low. That doesn't necessarily mean that they are estrogen dominant or that we should be worried about a potential PCOS case. But what's happening here is that the estrogen may be at a completely normal level, which would cause your provider to say, oh yeah, see, you're normal, you don't need anything. But when your progesterone is too low to be comparable to that, you get this kind of like uneven seesaw effect. And what can happen is then you can be displaying estrogen dominance type symptoms, even though your estrogen is at a completely normal level. And so this can look like what we call the 5Bs. And so we can get bloating, breast tenderness, blemishes, bleeding, and bitchiness. And these are some of the most common symptoms that my patients in perimenopause or even like age 35 are starting to experience. And it is simply because that progesterone is too low compared to balancing out where that estrogen level is. So if we just supplement a little bit, we can relieve a lot of those symptoms. Now, before I continue on, I want to make a really, really important note here in that there is a difference between bioidentical progesterone and progestins. So a second common thing that we generally see is, oh, well, just go on a birth control. That gives you some estrogen and it's going to give you some progesterone. Or you go on a progesterone only birth control. However, birth controls are progestins. So they are synthetic versions of progesterone. And this, if we go back to the WHI study, is what actually showed that risk for that increase in cancer and all the cancer scare that happened in the industry. It was actually from the arm of the study of patients who are on progestins. And so when we are using a bioidentical progesterone, we avoid that issue. So very, very important when we're going through this that it is made completely clear that we are not talking about birth control. We are talking about prometrium or bioidentical progesterone. Now, we do have a lot of patients who still do need to be on a birth control for pregnancy prevention purposes. And so obviously that's a discussion that you're going to have with your OBGYN, and that's a decision that you're going to make for yourself, which form works best for you. But we do prefer an IUD if you do need to be on birth control. And why this is that although you are still getting a progestin, it is not a bioidentical progesterone. When you have it in an IUD form, that stays more localized to the uterus. And so you're not getting as big of a systemic effect from that. So it's not going to be quite as risky. Also, if we go back to when we were discussing about testosterone, we know that birth controls cause your SHBG to raise, which then eats up your available testosterone. So you have less testosterone that your body can use. When you're using an IUD, that localized progestin, again, is not so systemic. So we do not see as much of a rise in that SHBG. So that can also help to normalize your testosterone levels a little bit as well. So it is our preferred method. But again, I do not use an IUD to control hormonal type symptoms or to use it for perimenopause symptoms. I strictly would use it for pregnancy prevention purposes. So that being said, there really is only one form of progesterone that most clinics are going to be using, and that is oral micronized progesterone. And for the most part, we can just prescribe this to your local CVS or Rite Aid or Walgreens or wherever you go, and your insurance should be covering this. There's generally two different strengths that we use, 100 milligrams and 200 milligrams. Now, we can also get this compounded at a compound pharmacy. And some reasons that we might want to do this are, number one, if you have a peanut allergy, we cannot prescribe to a regular pharmacy because the way that the product is made, there is peanut oil somewhere in the production process. And so obviously you would have a severe allergic reaction. So in that case there, we would have to use the compounded version. Now, another reason why we might use a compounded version is maybe even like the 100 milligrams is too strong for you. You're too sensitive to it. So we may need a 50 milligram. We may need an extended release version instead of the immediate release, and those are not available commercially from a regular pharmacy. The third reason why we might want to compound it is that at a compound pharmacy, they have to be within a certain percentage of what they say the dosage of their product is to follow regulations. And when you look at a regular pharmacy, something like a CVS, it is a much bigger margin that they are allowed to have. And so as long as you are sticking with the same pharmacy all the time, it shouldn't be an issue. But if you're picking up your prescription from Susan Street, and then the next time you're picking it up from Congress Street, and then the next time you're picking it up from the corner of Brookhurst and Warner or something like that, you can have varying degrees of the actual strength of that medication. And when we're taking progesterone, small changes in the dosage or withdrawing the dosage as a whole can lead to withdrawal bleeding, especially when you're in full-blown menopause. And so no woman wants bleeding when we're not expecting it or any more than we have to have it. And so this is something we really try to avoid. So those would be reasons why we might use a compound pharmacy, but otherwise you should just be able to go right to your local CVS. Your insurance should cover it. You should not have to pay out of pocket for this. There is one more form of progesterone that we can use, and this is a cream, just like all the other ones we've talked about. We don't generally use this one that often. It does have better absorption properties than testosterone or estrogen. However, the oral form tends to work better. It's much easier. We're not worrying about first pass with that one. And the only time I would really ever go toward a cream is if somebody was just having extreme sensitivity issues to even the lower dosed oral forms. But otherwise, it's just not something we generally reach for, and it's just not commonly used in practice by anybody. All right, guys, so that is all that I have for you today. It was another quick one. I hope you guys enjoyed this little mini series on the different forms of bioidentical hormone therapy replacement options. And stay tuned. I can't wait to see you on the next episode of The Retreat Radio. Bye. The information shared on this podcast is for educational purposes only. It reflects clinical experience and opinion and is not intended to serve as a diagnosis, treatment plan, or medical advice. As always, please consult with a qualified healthcare provider before making any changes to your health, medications, or treatment plan. If you want to be a part of our community, make sure to follow us on Instagram at theretreat.wellness and theretreat.aesthetics. Thank you so much for spending part of your day with me today, and until next time.